I want to welcome everybody and thank everybody for coming. Obviously, the biggest thanks go to our guest speaker tonight, Dr. Nicole Didyk.
Thank you so much, Robin, and thanks to everyone. I'm sorry that this is over the supper hour, so yeah, please feel free to eat or do whatever you need to do while watching the presentation. And I'm so thankful to Robin for sharing the slides, so they will be available. And this video will be put up on the Alzheimer's Society YouTube as well pretty shortly. So if you miss anything, you'll be able to catch it on the replay. But what we're going to talk about today is entitled After the Diagnosis of Dementia. And this is a lot of what I see in my practice as a geriatrician. So a lot of my work is making the diagnosis, but then there's often some things that come up afterwards as well. So I do mention patients, but of course I won't disclose any personal health information. So any patients that I describe are sort of a composite of people that I've seen. They're not actual people. And of course, this isn't, a medical advice. So if you want to try something that I mention here, talk to your healthcare provider about it first, but don't use my advice. So what we're going to talk about today, these are sort of the objectives, but I hope we have lots of time for sharing afterwards, and I can try to answer any questions, or I'd love for you to share with me your experience. So we'll talk about how to have difficult conversations after the diagnosis, especially if it seems like somebody is in denial or can't seem to accept it. We'll talk about some of the more challenging symptoms of dementia, so those that are surprising, severe, and maybe complex to manage. We'll pick out just a few of them because there are several of those. And then we will talk about validating and dealing with feelings of helplessness and grief. So we'll spend a little bit of time talking about that. And so those are some serious topics today, but hopefully we'll find some hope and some positive information too. So I'll introduce you to my sort of composite pretend patients here, but this is Gerard and Francine. And Francine happens to be, they're a married couple, and Francine is Gerard's second wife, but they've been married for 20 years. And Gerard is a retired illustrator. So he is quite an accomplished artist, highly educated, but the family has noticed changes in his memory for a few years, and really more noticeable over the last 1 year, such that it gets in the way of his day-to-day life. So he used to be able to manage the finances and do the taxes and manage their investments, and he was starting to have so much difficulty with it that actually Francine and his kids have taken over. And he's having a lot of trouble with language and word finding, which is really noticeable. He's a pretty healthy guy. He has some prostate enlargement, but doesn't have prostate cancer. And he did have a severe head injury about 40 years ago as part of a car crash. So he has that history of head trauma. Now, when we did cognitive screening in the office, he scored below what we would expect for somebody with his age, education, and life experience. And we'll talk a little bit more about memory tests a bit later. But his score on that MOCA test was 17 out of 30. So putting the whole picture together, Gerard has a diagnosis of dementia. And we disclosed that, and we started him on donepezil. And we kind of talked about what the next steps were. And he was driving. He continued to drive just short distances. And his wife thought it was fine. Gerard thought that was fine. But his kids were worried about it. So we'll talk more about that later. But, sorry, can you hear my dog barking? Sorry about that. Somebody must be coming home in my household. So, so there's kind of a spectrum of brain changes, and I'll just start by spending a few minutes talking about dementia and what it is, and probably most of you have some familiarity with this. But as we get older, there are some changes that are a normal part of aging and some that are not. Now, 5% of the population does not have any change in memory as they get older. So we call those people super normal. And that's the same percentage of people who don't get gray hair. So it's not the same people who don't get gray hair and also don't have memory change. That would really be unfair. But you know, it's a small proportion of people. So most of us have normal changes in brain function as we get older. And the changes that we might notice are in our fluid memory rather than our fluid intelligence rather than our crystallized intelligence, so to speak. So, you know, the good news is that as we get older, some things improve. So we can develop what you might think of as wisdom. You know, we can continue to develop our vocabulary, our general knowledge. We can hang on to our procedural memory. So things that we've long known how to do, we can continue to do. But we might have more difficulty with new tasks, for example. So you might need to keep the handbook that comes with the new microwave, whereas before you could kind of learn it and then just throw it away. Now you kind of keep that around. You might need to bring a grocery list to the store, and you might need to pull out a pad of paper and a pencil if you're trying to calculate a restaurant tip. We all look forward to those days when we can calculate a restaurant tip again. So that's normal. And at the other end of the scale is dementia, or what we're calling major neurocognitive disorder. And major neurocognitive disorder is where there's definitely an effect on day-to-day function. So people are noticing changes in their memory and other domains of cognition. It's not, it's a change from how things used to be. It's not due to some other cause, and it's having an impact on day-to-day function. So you can see here, and then in between normal aging and dementia is this category called mild cognitive impairment. And mild cognitive impairment is kind of where there's trouble with memory performance, but there is no trouble with day-to-day life. So that's not dementia, but it's considered a risk factor for the development of dementia. So you can see that, you know, we use things like cognitive screening to distinguish between normal aging and mild cognitive impairment. And then we look to see if there's any functional impairment or changes in day-to-day life. And that's what helps us to distinguish between dementia and something else. And so this is just sort of another way of conceptualizing that. But you know, this arrow is a little misleading because normal aging doesn't necessarily lead to mild cognitive impairment, and mild cognitive impairment doesn't necessarily lead to dementia. So they might be on the same continuum, but they don't necessarily, it's not a necessary progression. So remember that Alzheimer's is one type of dementia. So a lot of people ask me, is it dementia or is it Alzheimer's, or has my dementia progressed to Alzheimer's? But really dementia is the umbrella, and Alzheimer's is one type of dementia. So there are other causes too, and some people have a mix between different causes. So there's vascular dementia, which is related to strokes and blood vessel changes. There's Parkinson's related dementia, which is usually after someone's been living with Parkinson's disease for a while. Dementia with Lewy bodies, which can look a lot like Parkinson's, but also involves dementia and usually some pretty vivid hallucinations. Frontotemporal dementia, which is part of sort of another family of types of dementia, which often causes changes in behavior and language skills rather than memory. So it can look pretty unusual and different. And then other causes of dementia exist as well. And the biggest risk factor for dementia is still older age. And we can see that in Canada, 8% of the sort of young old are living with dementia, 11% of those in that mid-range, and over the age of 85, it's about 35% of people. So there's almost 750,000 persons living with dementia in Canada right now. And of course, that's going to go up as we have more older adults in Canada. So we've kind of talked about the definition of dementia, and you'll notice that it's not due to delirium or something else. So those things need to be ruled out. And that's a big part of my job, is making sure that it's not part of a depression or some other illness or some kind of a metabolic problem or medication related. And that's what can make dementia challenging to diagnose. is that it's not usually that we can do a blood test or a scan, or even a maneuver in the office to diagnose it. The diagnosis is made based on taking the history from the person, and talking to their family, their friends, other people in their lives, and finding out how things have been going. So, and oftentimes we have to get that history from others as well. It's not enough to just talk to the person. We have to kind of get that, what we would call collateral or corroborating history. And we do have to hear about those memory changes, but also that it's getting in the way of day-to-day life. And so sometimes people at the end of an assessment, they'll say, well, why do you think that? That's just what my husband is saying, or, you know, that's what my kids think. I don't think that. So it can get very fraught and challenging. We do use these kinds of memory tests, and this is a bit of an out of focus picture, but you might recognize some of these cognitive tests, and maybe you've done them, but they're just a part of the picture. So they don't diagnose a dementia. You can't pass or fail a cognitive test. The first one here with the animal pictures on it, that's called the MOCA. And basically this test was designed to help us screen for people who might have changes in their brain performance that's outside of what's a normal range. So people who are living with Alzheimer's especially are very unlikely to get a score of 26 or above on this test. But if they get a score below 26, it doesn't mean it's dementia. It could be a lot of other things. So these screening tests are important, but they're not diagnostic. So sometimes people will say, well, show me on that paper, you know, where I went wrong and what I did wrong. And that's not usually a productive sort of road to go down. It's just one tool that we use. And looking at Alzheimer's as an example of dementia, we were kind of, you can see this slide is about 20 years old. So we were kind of taught, well, the changes in the behaviors usually happen kind of later on in Alzheimer's. So at first we see changes in mood, and then, you know, later we might see changes in memory, the typical changes, then an impact on function, and eventually later on in Alzheimer's, unfortunately, there's changes in mobility, as there are with other types of dementia as well. And we sort of thought those behavior changes happened later on in the course of dementia. But I would say, based on my clinical experience, that orange behavior line can happen at any time. And it might even happen before the memory changes and the life skill changes. So that's something that, you know, I would revise this diagram and point out that the behavior changes can certainly be prominent early on, and that can make diagnosis and living with dementia very complex. So let's go back to Gerard and Francine. And Gerard, we diagnosed him with Alzheimer's, and it's been about 6 or 9 months. And Francine brings him back in and says, you know, you got to help me with this husband of mine. He went for a driving test. He didn't pass. His license is now suspended, and he is just despondent. Every single day he's constantly saying, why can't I drive? Why can't I drive? And why? And if I tell him it's because he has dementia, he wants to know why, and he doesn't believe me. So Dr. Didyk, you need to tell him that he has dementia and he can't drive, and then he'll get it, because he, you know, he respects you, he respects authority. Just tell him and he'll be able to move on. And of course, that never happens. So that's not an uncommon scenario in my work, but you know, it's that frustration and kind of coming to grips with some of the changes, that some of the symptoms of dementia that can produce these kinds of difficulties. So let's take a little closer look at some of the symptoms of dementia. And these are the ones that in my practice and my experience of almost 20 years of experience now, I find that they can be the most difficult for people who are living with dementia and their families. So we talked about memory change, that's amnesia, right? We could call it that. But then there's also these other A's. So there's agnosia, or difficulty with recognizing, right? So that could be recognizing people or familiar places or objects. And then there's anosognosia, which is not recognizing that you don't recognize. And that's all, can also be sort of seen as like a lack of insight, or that's where people might mistake it for denial. So they might just think, why doesn't he know he has dementia? You know, he's been told that. I tell him that every day. Why doesn't he get it? But that is one of the symptoms that I think it's worth talking about a little bit more. There's apraxia, which is where someone has trouble with something because of their cognitive skills. So if we look at driving, somebody might have perfect vision, good reflexes, good motor skills, but because of the brain changes, they aren't able to do it properly. And so that can be hard for someone to understand, is why, you know, people can understand if their vision is impaired, that's why they can't drive, but it's harder to understand that it's because of my brain and how that's changed. Changes in language could be referred to as aphasia. And then these responsive behaviors. So responsive behaviors have gone through many different names throughout my career. We used to call them dysfunctional behaviors and just plain old behaviors, or just sometimes just called aggression or agitation. But they're actually a response to something that's happening to the person who's living with dementia. And so the challenge is to find out what it's in response to and try to respond to the response. But what those behaviors can look like can be things like apathy and depression, sleep problems, or getting lost. All of these are very difficult. But let's zone in on just a few of these things. So let's talk a little bit more about the anosognosia. Let's talk about driving, and let's talk about apathy. And you can let me know maybe in the discussion part if there's another symptom that you find to be very challenging. So anosognosia, or not knowing that you don't know. And there's been a lot of study actually about, do people who are living with dementia sort of know that they have this diagnosis? And a tool has been developed to measure that. And so, but it really depends on the population and the study that you look at as to who's living with dementia, how much awareness there is. So using this in this review by Dr. Alexander here, they found that about 14% have a fairly acute awareness about the dementia and the effects that it's having on the person. And about 41% of people had some limited awareness that they're living with dementia. But you know, the rest of people, perhaps not the majority, but most, I guess that is the majority, but a large proportion of people don't really seem to have that awareness. And so that can be extremely frustrating for the care partner and for others, because it's, you know, it's like Francine has kind of expressed to me in the office, right? Like, why don't you just tell him and then he'll get it? And then I can say, yeah, honey, I have to do this for you because of your dementia, you know, and life will be easier. But it's a bit of a double-edged sword, because if people are aware that they have, that they're living with dementia, for some, it can bring sadness and anxiety and grief. It's, you know, which we'll talk about later. So it's, you know, in some ways that limited awareness could be a positive thing. So if somebody isn't recognizing that they have a dementia or that they need help or something else, how can you respond to this? And there's a few different ways of responding that I found in the literature. So you can try reality orientation and just tell the person, you know, how you see things on your reality, and insist that that's the way it is, and sort of try to convince them, or just, you know, just constantly reorient them to how things are. And many people feel that for ethical reasons, this is the way to go. And that's, you know, that's the only way to go. But that can be a challenge sometimes. So an example might be if somebody is facing a transition, perhaps into long-term care or another type of setting, and talking about that every day and sort of saying, okay, now it's 10 days before you go, now it's 9 days. I mean, that can cause a lot of anxiety and upset. So for that, in that situation, you might want to try something else, and that you might want to try a fiblet, right? Or a therapeutic lie, And that involves redirection, but using some bending of the truth or outright lying in some cases. So you might say, well, you're going to go to this home and we're just going to see how you like it. You know, and you might say that, but you might also know that that their house where they're moving from is going to be sold, and that's a permanent move. But if for the sake of smoothing this transition, you might use this little therapeutic lie. And that'll, you know, you can see it as being for the benefit of the person because it won't upset them. But some people really have an ethical problem with that. And so I came up with this framework published by Dr. James and his group, and it was trying to develop some of those ethical guidelines. So this was, and sorry, this is such a wordy slide, but basically this was like, okay, well, if we're going to be in, and Dr. James was sort of brought this up in the setting of like a retirement home or a home for older adults, long-term care home perhaps. So because that does come up there quite a bit. So if somebody, you know, wants to go home all the time, what should we do? Are we going to tell them, you know, this fiblet to help them feel better? So here's the framework, right? You should only tell them if it's in their best interests. The lie, once the lie has been agreed upon, it must be used consistently. So let's get our story straight, you know, and make sure that if I'm telling them that, you know, they're going home next week, and you tell them that, you know, their home is burned down, like that's going to be confusing. So let's all make sure we have the same story. Let's make sure that this lie has been written down somewhere. And you know, let's make sure that it's, you know, the management is in on it and that we're trained and all of that. And I'm being a little bit facetious, but, you know, I commend them for looking at it in kind of an honest way and saying, okay, well, if we're going to do this, is there a way to do it that kind of would feel okay ethically? And I confess to sometimes using these approaches and sometimes encouraging people to use a bit of a fiblet approach in some situations. But it always does feel a little bit, you know, a little bit dishonest, and I can understand people having an ethical challenge with it. So another approach is the validation method, and many of you have probably watched some of the amazing work and heard Naomi Feil speak, but and she talks about most of her work about validation, the validation theory and validation method is in older adults who are, she calls it maloriented or disoriented. So perhaps going back in time and wondering where their parents are or their partner who's passed away. And but you can think about it in the setting of this anosognosia or not recognizing a diagnosis. So some of the principles that Naomi brings up is that if we accept the person living with dementia and recognize their value and recognize that they may have this conflict going on that might be difficult to articulate. So perhaps seeking resolution of something in life or trying to restore balance in the face of the dementia diagnosis. And that might be why it seems like there's difficulty accepting the diagnosis. And so rather than lying or rather than reorienting, what we should do is acknowledge and validate the person's point of view and listen with empathy in an effort to build trust. And her position is that that'll reduce anxiety and restore dignity. And she points out that people who are living with dementia can live on several levels of awareness, often at the same time. And so people who are living with dementia who don't seem to get that they have dementia, there's probably a part of the person that does get it, at least part of the time. And we can imagine how difficult that would be and sort of the pain there. And that does need to be validated and to be heard with empathy. So I like the principles of the validation method. I think that there can be challenges with executing, and it probably does require some training and the same type of like getting everyone on the same page as would happen in the therapeutic lie, but it certainly seems very compassionate and very, a very sort of human and validating approach. And we'll come back to this idea of validation a little bit later when we talk about grief. So I'd be interested to hear what you think about this. Let's talk about the apraxia and the driving. Changing gears a bit, pun intended, I got to admit. Driving is something that comes up a lot because it's such a high safety bar. And it's also a legal issue, right? So as medical professionals, if we know that someone has a diagnosis of dementia or something else that could affect ability to drive, we have to report the person. So the other thing that we know is, there are things that can affect driving ability aside from doing an assessment. If a person is in a moderate to severe stage of dementia, then they're more likely to have a problem with driving. Certain types of dementia are really incompatible with driving. If there's been a history of a car crash in the last 2 years, some of the memory testing is thought to correlate with driving skill. And if a family member tells us that they're worried about driving, that's usually worthy of paying attention to that, because family members are generally very protective and oftentimes even have a conflict of interest in wanting the person to keep driving. So usually if a family member brings it up, it is an issue. But we know at the same time that the loss of someone's driver's license can lead to depression and definitely can worsen social isolation and can be a huge loss. So what should you do? Well, validation is important. Validating the person's feelings, and it can be tempting to say things like, well, driving's a privilege, or statements like that, which is true, but it's often good to throw Dr. Didyk under the bus on this one. So, I think that, and that's something that I think a lot of my colleagues notice too. Family doctors will sometimes say, I've made the diagnosis of dementia, it's pretty obvious, but we've got to talk about driving, and I need to maintain a therapeutic relationship with the patient. So they'll send the client to me as a specialist to kind of cover this issue so that they can preserve that relationship. And so that might be helpful. So if people do have some tendency to kind of be compliant with what a doctor recommends or a professional recommends, you can say, it's a medical thing. And sometimes that, along with the validation, can help somebody to eventually move on, but it can take a long time. Driving tests, sometimes people will that'll have an impact. So if we actually have someone take a driving test and not be successful at it, sometimes that's enough for people to just kind of have that vivid of an experience that they will be able to kind of move on after that. And sometimes people do have to take practical interventions like disabling a vehicle or calling police or something like that, but hopefully that's a last resort. But that's one of the most difficult issues and conversations is around the driving, but it eventually will pass. I've never seen anybody sort of hold the driving grudge forever. It's eventually something that will at least diminish. So it might be something that somebody mentions every week, but not every hour forever. Now let's talk a little bit about apathy, because this is something I'm really seeing a lot of now, especially during the pandemic and the lockdown. And I know I used to think, I would hear a lot of people, care partners that really had difficulty with this apathy. And I would think, wow, there's so many worse responsive behaviors. Like people could have day-night reversal and you're finding that they're napping too much. Like, come on, count your blessings, But that was dumb because it is very hard to live with. It's very hard to see, and especially in people who, the apathy is like a way of losing the person that the care partner has known for a long time. And apathy is really that diminished drive or initiative or motivation. And it can even translate into a decrease in expression, even verbal expression and interaction. And it affects 30 to 90% of those living with Alzheimer's at some point. And it can be a predictor, and other types of dementia as well, especially frontotemporal dementia, and some types of vascular dementia, and the apathy can be very prominent. And it can be a predictor of decline as well. Because apathy can make someone just spend a lot of time on the couch or in bed, which leads to physical weakness. And that very quickly will translate into a loss of functional ability. So if somebody has more trouble getting up, they'll have more trouble getting to the bathroom. And so they might start to live with incontinence or other things like that. The less somebody wants to move, the more they're socially isolated. And it can be a bit of a vicious cycle, right? So we're more physically isolated and socially isolated, socially distanced. And so we're moving around less, and you can kind of get into that languishing type of mode that's trending right now. And if somebody is in rehab, for example, we might see that when they have apathy, there just isn't that motivation to progress with rehab. And we can see people go backwards with their mobility and such. And it really does put a strain on care partners. So my approach when I hear about apathy, I really do want to rule out depression. Apathy can be a very prominent symptom in depression. But to make a diagnosis of depression, we also have to see usually low mood or a symptom called anhedonia, which is loss of pleasure in things that used to be very pleasurable. So if we don't have those features, then it's probably not depression. It's probably just this responsive behavior. And then we have to look at downers too. So and things that we might not consider. So when I say downers, I don't mean the negative people in your life, but I mean not the Debbie Downers necessarily, but also the downers that somebody might be consuming, like alcohol, benzodiazepines or sleeping pills. So other medications that might be just flattening a person out a little bit. So maybe if you needed them at another stage of dementia, perhaps now that the person is having more apathy behaviors, we don't need those medications anymore. So what are the therapeutic interventions that we can use? And so most of these in the studies that I read were done by trained professionals, so musical therapists or recreational therapists, for example, or people who had been trained in art therapy or therapeutic conversation. So those are really great if they're available, if they can be done safely from an infection control point of view, and if the cost is reasonable. But even things like the Alzheimer's Society has a lot of programs that have gone online, right? So that they've always had the music program with iPods. There are Minds in Motion that's happening online and so on. So it's really not the same, and it can be harder to engage, especially if you're living with apathy. But those things are available, and the Alzheimer's Society can definitely help you with things like getting the technology up and going. So, and older adults are amazingly able at technology. I know my parents are on their iPads every day, and they will send me emails and photos, and they will live stream all kinds of stuff. And about 70% of older adults are on the internet very regularly. So it's not as much of a barrier as people might think. So it can be done, but it's challenging. A lot of people tell me they feel like they have to be a cruise director, and kind of on top of all the other care partner things they have to do, they kind of have to organize the social life. But that's something that might be worth putting the energy into. So we've touched on this a little bit, but maybe for the rest of the talk, we can talk a little bit about the grief that can be part of dementia. And the grief in dementia is complicated. So there's probably 3 different stages or 3 different ways of looking at it. But if we the 3 ways, I guess, would be anticipatory grief. And then there's ambiguous grief, which is kind of the same as the anticipatory grief, or it's also sometimes just called dementia grief. And then there's the complicated grief after the person does pass away. So there can be many stages, and some people move back and forth between these stages. But here's a definition of grief that kind of made sense to me in this context. So the reaction to the perception of loss. And it can have symptoms including yearning, sadness, anger, guilt, regret, anxiety, loneliness, fatigue, shock, numbness, positive feelings even, and a variety of physical symptoms that are unique to the individual. So nobody grieves in the exact same way. And I was really struck in this definition by the physical symptoms that are mentioned, because they're definitely real. And ambiguous loss is another grief element that comes up a lot in dementia. And it's been described as when a loved one is physically present, but psychologically absent. And of course, that can happen to varying degrees, but I have heard many people share that type of sentiment with me. And we've heard different ways of describing dementia that kind of explain that, or express that, like the long goodbye and so on. So the grief of dementia can be anticipatory, and this is often felt by the care partner, could be felt by the person who's living with dementia as well, of course. But the care partner often grieves that loss of companionship and personal freedom and control. And the anticipatory grief is different because it's born alone. So a lot of grief culturally is shared with families and other people in the person's life. But if you're a care partner, you're often feeling this grief by yourself, which makes it hard. And it's a risk factor for depression, which again, which can have effects on lifespan and so many other important things. So this anticipatory grief is important. And it can also be a risk factor for having complicated grief after the person passes away. So 20% of care partners of those living with dementia have a complicated grief reaction, which might mean that it is the grief is protracted, it's extra long, or particularly painful or difficult, or leads to a full-blown depression. And this complicated grief is more likely in spouse care partners rather than children or other types of care partners, and those who did have a depression. So in the literature, there were a few different ways additionally of looking at grief. And I thought this one was interesting. And Muser and Marwitt have developed this caregiver grief inventory, which has been looked at a lot in dementia. And they came up with some interesting contrasts between how care partners might respond to or how they might move through grief, whether they're the partner of the person with dementia or the person with dementia is a parent. And I thought this was kind of interesting. And I've seen elements of this. I can't say that I see a particular pattern all the time between children and partners, but it kind of made sense to me. That in that early stage of dementia, there might be, the partner might have more acceptance for this, because oftentimes they've started grieving even before the diagnosis and noticing that things have changed and kind of reframing what the future is going to look like. And so there might be more acceptance, whereas the child might just simply be in denial about this. As the person moves into a more moderate stage, the partner might really be feeling sadness and really empathizing with the person living with dementia and really wanting to preserve that relationship and grieve how much it's changed and how it could have been. Children of parents who are living with dementia might be more angry and frustrated, and they might even have thoughts of thinking about that the person who's living with dementia may be better off if they were to pass, and then they feel guilt about that as well, understandably. And grief for sure flares up when there's a transition. So either if the person passes away, or more commonly if they move into another setting. So there's relief as part of the grief. That can be one of the positive emotions, but definitely feelings of guilt and sadness and failure are a part of that too. Another model of looking at dementia grief is by Blandin and Pepin, and they kind of divided into 3 phases. So they divided as being, and this brings up validation again, which I thought was an interesting echo to what we talked about before. So that there are those losses, there's the separation, the liminality, which is like a threshold, and then the reemergence. And that this is a cycle, and it can sort of happen over and over again as people go through different phases and different experiences with their dementia. And they mentioned too that there can be roadblocks to working through the grief along the way. So the losses need to be acknowledged and recognized. If they're denied or unacknowledged, then the person might sort of stay in that separation grief and just be reflecting on the loss and not be able to work through it. And then the same thing, moving beyond this liminality or threshold state or this ambiguous loss state. If you validate and kind of tolerate those feelings, you can kind of reemerge at the end into acceptance and adaptation. Or, you know, that would be the healthiest way, I guess, to go through this cycle. And if there's avoidance of those feelings, then that might, you know, it might be that we're stuck in ambiguous loss a little bit longer. So that model made some sense to me as well. But what helps with grief? You know, I think that, or, you know, what I found in kind of looking it up was that there was very little high quality evidence as to what helps. And there's certainly many interventions, including things like counseling and peer support. If there's depression, that absolutely needs to be treated. But oftentimes other interventions can help. To try to reduce the depression in the care partner, for example. Apparently venting does not help. So that was one thing that I came across, was they said ventilating your concerns doesn't necessarily help. So I suppose in a peer support group, it wouldn't just be a venting type of session, there'd be other things there. So what might help based on what I've read is again that validation, right? Validating the grief, the feelings of grief, acknowledging them, and just sort of tolerating them such that there can be a reemergence afterwards towards acceptance. So I don't know that people will necessarily feel better, but they'll feel, you know, there will be sort of a processing. And oftentimes reframing roles, so kind of anticipating what's coming later. And I think that's a big job of the Alzheimer's Society, a job that the Alzheimer's Society does extremely well, is taking stock of where things are now and thinking about what might be coming, and having a little bit of anticipation and planning ahead. That can be very helpful in regaining that sense of control and balance. And I put encouraging self-care, but it's a word that gets really overused, and I think it's a marketing word now, you know, that it's kind of to sell us bubble bath and spa experiences and that. But self-care is often more about taking time for ourselves and saying no to things and actually stepping back from some responsibilities and letting some things slide, or asking for help when it's needed. Or, you know, making trade-offs that we need to make that we might not have made. So kind of like giving ourselves a break rather than just taking a bubble bath. So that's what I mean by self-care. And I think that can be very important in mitigating depression and helping to move through grief. So I learned a lot from Francine and Gerard, and I mentioned that Gerard was an illustrator, and he was also a very accomplished painter, and he journaled and kept sketchbooks throughout his whole life. And he and Francine had traveled, and he had also traveled a lot in his earlier life with his kids as well, and his first wife. And you know, I learned a lot when Francine brought in some of his work. And I think it was about the third or fourth time that we met. And she said, you know, I know Gerard has changed a lot. I know he's had a lot of these losses, but I just want you to know who he is. And I just want you to know what his work was about, and you know, what was meaningful to him and to us. And yeah, just who he is. And I have a piece of his work, and I look at it almost every day. In fact, it's hanging up in my office. And so I really learned a lot from that experience. And I think that this is kind of an example to me of validation, that that Gerard is living with dementia, but he is an artist, and he's, you know, he can live in that reality of him as an artist, as well as he is now, as we might see him in our plane of reality, as a person who's living with dementia. But both can coexist. And I think that kind of lies at the heart of a lot of the grief and the adjustment to the dementia diagnosis, is that, you know, we need to remember the person, and we need to validate the person, and recognize that there is a lot of change, but the person is still there. So I think that's one thing that people can do as care partners too, is to advocate and to remind the care team that of who that person is. Because it does make it much easier to understand and to help with validating what they're experiencing, even when it's difficult. So that's kind of all I have to share. These slides will be shared. I think Robin said, so if you want to look at any of them more closely, I've added some of the papers that I read in preparing this. But there's so much more that's been written, and Alzheimer's Society always has some really good resources about many of these topics as well. So if you want to catch up with me, you can certainly find me on my website, thewrinkle.ca, and the YouTube channel of this, I was going to say YouTube challenge. It is very challenging sometimes, but channel of the same name. I'm on Facebook and Twitter as well, but if you want to check it out, that'd be great. And tell me what else you'd like me to write an article on or do a video on, and I'll try to make that happen. So I'll hand it back over to Robin and the team.